Lilit Ganjalyan from Armenia, and the head of our department, Levon Davtyan, is now here in this hall. Today I'm going to talk about pediatric liver tumors. As we know, solid tumors make up about 30% of all pediatric cancers, including Wilms tumor, neuroblastoma, CNS tumors, bone tumors, and finally liver tumors. And liver tumors can be benign and can be malignant. It's very important to know all about them for differential diagnosis, because usually they have similar appearance on imaging techniques. So clinical presentation usually includes palpable mass in the abdomen and some constitutional symptoms. And the age of patient is very important consideration in the differential diagnosis. Next, when I was preparing for this report, I found an article when there was written about pediatric liver cancer, and there is written about children who have liver cancer, and then they need a special team which include some different specialists, but I couldn't find the radiologist word in the article. So I have a question, why? And imaging techniques play a crucial role in the management of a child suspected with liver tumor, and we have three main imaging techniques: ultrasound, CT, and MRI. So, as radiologists, we must help oncologists and surgeons to understand simplicity and to understand how they need to do the surgery, whether it is resection or the transplantation. So, first I want to introduce you with some features from radiology. Here we can see the transection of the abdomen. We can find internal organs here. And next we have the transection of a CT. And as younger people are more sensitive to radiation, then we must do only one CT scan in children to reduce the radiation exposure in them. So here we can find liver, we can find great vessels, we can find spleen, and we can find stomach. Next, we have similar appearance on MRI. Here we can find liver again, great vessels, spleen, and stomach. Next, there are many questions that can be answered only by a radiologist. And first of them is about pretext number. Pretext number describes tumor extent before any therapy. It is used for baseline surgical evaluation in all cases by calculating the number of contiguous sections that are involved in the tumor and that there must be resected to completely remove the tumor. And it is based on quinoid segmentation. As you know, we have 8 segments in the liver, but we have 4 sections. And according to pretext number, we have 4 types of tumor. First one is the best, and the fourth one is the worst. Next, we have first type. We can see the tumors that are located in the marginal sections of the liver. And we have 3 adjacent tumor-free sections. So next one is second one. We can see that the tumor includes 2 sections of the liver, and we have 2 adjacent tumor-free sections here. Next one is about third type. Third type, we can find the tumor in 3 sections of the liver, and we have only 1 section that is tumor-free. Next, we have another type in this grade. Yes, here we can see that tumor are in 2 sections of the liver, but we have 2 sections that are not tumor-free, but they are not adjacent to each other. So it is fourth type, it is the worst, and we can see that the tumor occupies all the sections of the liver, and now we don't have any tumor-free sections here. And I made for you some quiz with cases. Here we can see the tumor. It occupies only 2 sections, and we have 2 tumor-free sections, so it is second type of tumor. Next, we have this one. We can see that it occupies all the liver, so we don't have here any tumor-free section. So it is fourth type, it is the worst type. Next question to the radiologist about the size, shape, structure. And here we can see the lesion. It is hepatoblastoma. We can describe it, its shape, its structure, but we can find classification in it. And as you know, more than half of cases of hepatoblastoma, we have classification in it. And it is very important information that will be in radiologist reports. Next, again about classification masses, we can see in abdominal X-ray gray calcified mass in the left side, and after it, CT was done when there was found the calcified mass, that was hepatoblastoma. So hepatoblastoma, as we know, most common primary malignant liver tumor in children. It occurs before 5 years. AFP level is elevated usually, and here the most common site of metastasis is the lungs. Next question, we can see it on MRI. As we know, MRI has 2 sequences, and here we can describe it, that is well circumscribed tumor with internal heterogeneous enhancement. Next, about distant metastasis. We all know that is most important information with a child with tumor, and here we can see a large mass in the liver. And next, when we see the CT chest, we can find multiple lesions in the lungs that are typical to metastasis. Next question about mass effect on the adjacent organs. For example, here we can see the tumor in the left lobe of the liver. It is the mass, and we can see the view, coronal view on MRI. And next, we can find the tumor-free liver tissue. We can find spleen, we can find stomach, but the stomach isn't its typical location because it is displaced by the mass, and it is about mass effect to the on the adjacent organs. Next, about vascular involvement. Here we can see ultrasound image, and it is 2-year-old boy case, and he has hepatoblastoma, and in inferior vena cava we can see intraluminal echogenic material on ultrasound. Next, CT was done, and we can find filling defect in IVC and right hepatic vein, so it is about vascular involvement or tumor thrombosis. So it is very important graphic for patient with some differential diagnosis based on age. We have here hepatoblastoma and HCC. They have similar appearance on CT and MRI, but HCC occurs in older patients. For example, here we can see the mass that is located in the right lobe of the liver, and it is a 15-year-old boy, and it is hepatocellular carcinoma. Next question, that is second most common primary pediatric hepatic malignancy, and it occurs often in older patients than hepatoblastoma, and AFP level here is also elevated. Next, about its structure, cystic structure. It's very important for undifferentiated embryonal sarcoma of the liver. We can see here cystic mass in the right lobe of the liver, and it is shown on MRI as cystic mass. Next, after hepatectomy, it is described as a well-circumscribed heterogeneous multilobulated mass. So it is undifferentiated embryonal sarcoma of the liver. And its prognosis is typically poor, and metastasis for this tumor is lungs, pleura, and peritoneum. Next, about hepatic mesenchymal hamartoma. It is main differential diagnosis for embryonal sarcoma, and as you can see in this graphic, it occurs in younger patients, but it has similar appearance on CT and MRI. And here I have 2 cases, which one there have similar appearances on CT, but one of them is hamartoma, next one is sarcoma. And when you pay attention to their age, we can find that first one is embryonal sarcoma, next one is hepatic mesenchymal hamartoma. So in conclusion, I only want one thing to add radiologist word in this article. Thank you very much.